but I hope as more bodies join us in the room this morning, then the warmth will spread around. So welcome again to what I expect to be a very interesting discussion. We have this morning with us some very distinguished panelists, and we're very happy that you're able to join us. Our focus in this panel is on priorities for youth health and wellness, and we have some experts with us here who are going to be sharing research and work that they've done around these issues. I'm Melissa McNeil Barrett. I'm the assistant representative at the United Nations Population Fund in Jamaica, and so the issue of youth and health is certainly an area that is very important to us at UNFPA and in the work that we do. So I'm very excited this morning to be here with our distinguished panelists. So without further ado, I'm going to introduce to you the panelists that we have here. Right next to me is Dr. Monika Asnani. I hope I pronounced Dr. Asnani's name properly. And she's a senior lecturer at the sickle cell unit. Her research focus is psychosocial and renal aspects of sickle cell disease. And she will be sharing with us information on the challenges and opportunities for development in youth with chronic diseases, the experience with adolescents with sickle cell disease. So that should be a very exciting presentation. Online, we have with us Mr. Norwell Hinds, and you can see him there on the screen. He is joining us from Guyana. He is the youth coordinator at GRPA, and Norwell will remind me what that stands for. I don't remember at the moment, but he has direct responsibility for the youth center. He's currently on the adolescent subcommittee for the International Conference on Family Planning, and he's a member of the NGO delegation to the Global Fund. So Norwell, welcome. Can you hear us clearly? Fair enough?
Can you hear the chair?
Not really, no.
It's low?
All right.
It's low and broken. I can't hear much.
All right. I guess the technicians will work to see how quickly we can fix it.
I can hear you clearly, but I can't hear her much.
Oh, maybe we might need to go over.
Your mic is probably the
It's built in.
Right.
It's close.
All right, so maybe
We can hear.
okay, yeah. So we'll work on that. All right, but we're very happy to have you, Norwell, on Skype, and Norwell is going to present on youth accessing sexual and reproductive health services from 2009 to 2014, a case study of the GRPA. And as I said, he'll remind us what GRPA stands for. We have with us Dr. Patrick James Toppin, who is currently a consultant in the section of anesthesia and intensive care at University Hospital of the West Indies, and he's also an associate lecturer at the University of the West Indies. He's pursuing a master's in public health with the University of Liverpool and is affiliated with the Violence Prevention Alliance in Jamaica. So he's going to be sharing with us this morning on patterns of violence-related injuries in 15 to 29-year-olds presenting to the Cornwall Regional Hospital. So again, another very interesting presentation. And at the very end, we have Taitu Heron, who is a development specialist and performance poet. Her areas of interest include rights-based development programming and policy development, gender, globalization, and citizenship in the Caribbean, and African diaspora cultures and post-colonial politics. And Taitu will be sharing with us on her presentation is entitled Make Them Stay With Them Law, Unsafe Abortion and the Agency of Women and Girls in Jamaica. So of course, again, another very exciting presentation. So I'm looking forward, and I'm sure you are as well, looking forward to hearing from each of our panelists. So let me say very quickly as well, the format of the session will be this. The panelists, each presenter will have 15 minutes to make their presentation. We will take all the questions at the end of the presentations. I think with the exception of our panelist in Guyana who has to leave after his presentation. So we'll probably take a 5-minute session, a set of questions for him so that we can allow him to leave. And we have a timekeeper here at the front who will keep us on our toes, particularly since we've started a little bit late, so she's Ms. Shamoy Hajari. Without further ado, I'm going to hand over to Dr. Asnani, who's going to share with us on her work and her team's work on the area of adolescents with sickle cell. Dr. Asnani.
Thank you. Good morning, everyone. I would like to stand. Yeah, yes, I need that. Morning, it's great to be here once again, because this happens to me many times, feeling like a square peg in round holes. You know, it's a little bit scary. I think some other presenters said that, but I'm glad I got an opportunity to hear what was happening this morning. It was I don't know, the first impression I had, and maybe that overwhelmed all of that, is that it was heart-wrenching, the video that was presented by you young people. Being a parent of 2 youth, I guess it's even closer to home, because I definitely want the best for them. And since having my 2 youth, I mean, they came to me as babies, but they are now youth. I feel all youth are my children, and I wish we could just do so much, because that's where the hope is. I am a medical doctor, so my presentation is a little bit different, but I'm very thankful to the committee and Terry Ann for giving us an opportunity to come here and talk about this work. And when my team, Mrs. Antoinette Barton-Gooden from University School of Nursing is here with me today, but there are others on my team, you'll see the names later, when she said, Doc, this conference is coming up, and it was on youth development, and I thought some of the work we are doing with youth with chronic diseases, in particular sickle cell disease, because we work at the sickle cell unit, and we thought it could fit in. So thanks for that opportunity. The team apparently here at SALISES thought so too. So we're talking about challenges and opportunities for development in youth who have a chronic disease they're living with, and I'm going to use the sickle cell disease as the prototype here. Definition I feel is a little bit different, because for me the adolescent I'm talking about includes as a part of your youth, I believe. The WHO, the World Health Organization, defines that period of life between 10 to 19 years of age. And this period especially, and I can go up to 21, 22 definitely with this kind of developmental issues that are happening in this time era. A lot of physical, psychological, emotional, and sexual changes are occurring during this time. And the period may be perceived as a negative stage of life almost, because there's a lot of work happening in that body, we said physically, psychologically, mentally, emotionally, etc. Almost like a period of storm and stress to be survived. A lot of issues are being faced by the teenager, by the adolescent, conflicts with parental figures, parent-like figures, figures of authority we spoke about politicians, but all parental figures, indulging in risky behaviors, mood disruptions, etc., which are quite prevalent during this time period. And they have many concerns, multiple choices that have to be made, career choices, reproductive choices, social choices, which are a lot more issues to handle than even when I was a youth, not very long ago. But definitely, I think our kids have to go through a lot more these days than we had to go through. There's a lot of stuff happening socially, and all of you sociologists and all understand this better. But what happens when this youth now is living with a chronic disease? Yeah, this period then becomes almost like a double-edged sword. The presence of the disease or the disability that the youth may be facing, going through, living with, has its own effects on growth and development, right, during this adolescent period. As well, many times, the normal developmental processes, puberty, all those changes that are happening physically, psychologically, mentally, can also impact the illness. So the illness is impacting their growth, and the growth itself may worsen many issues related to their illness itself. So it's a double-edged sword, and the presence of a chronic illness may magnify the many physical, social, psychological challenges that we said the teen already is facing. And as I said, I'll showcase this with sickle cell disease. Alright, so sickle cell disease, I'll start with a slide. How common is it? It's a genetic disorder, you're born with it. So say versus a flu or a HIV, which is a communicable disease. This is what we call an NCD, or a non-communicable disease, but it's a chronic disorder. And just about 0.7% of the Jamaican population, figures are very similar for the Caribbean as well, has sickle cell disease. Out of every 150 live births occurring in the island, one baby is born with sickle cell disease. And at the sickle cell unit, which is right across from SALISES, I hope you all know it, about 25% of our attendees fall in the 10 to 19 year age group. So we have a lot of children and babies, but we also have a lot of other youth, 20, 22, 25-year-olds and so on. So it's a genetic blood disorder. the issue is it's chronic, you're born with it, and you live with it till your final days, unless the very rare case who gets a bone marrow transplant, which is only treatment available. It's very chronic, and it has multiple unpredictable presentations. It can lead to frequent hospitalizations, many complications. Pain is a hallmark of the disease. They have severe, unrelenting, unpredictable pain. They have many other complications. It can affect you from head to toe. Often causes frequent absences from school and may hinder intellectual ability and hence affect employment opportunities. It can cause significant disruptions in the lives of persons who have this disease, as well as in their caregivers. Their families can be affected. You imagine you have a child or a youngster who has to be hospitalized. You look at the structure, how many times a parent might have to miss work and all kind of things. It really can disrupt lives. And of course, any chronic disease places a significant burden on the healthcare system. As care has improved, there have been many advances. So whereas 30, 40 years ago, a lot of persons with sickle cell disease, for example, died in their youth years, a lot of them are now living very well. We have patients in the office in their 70s and so on as well. But then as clinical care advances, health is improving, thank God, clap, clap. But what happens is they are now facing a lot more of the psychosocial burden that the disease is facing. And our unit pays attention to that. The pointer doesn't point to this one. And we are doing work in a lot of issues, psychological issues that they face. So not just life-threatening physical complications that might be having, but we know the importance of paying attention to their education, employment, and family support, the stigma that they face, and so on. Maybe we could spend 3 days here talking about sickle cell disease. So there are a lot of issues that the adolescent will face, and I'm going to showcase the kind of problems that a youth with any chronic disease can face. Showcase it using some local data. Over the last 10 or so years, we have thought that we need to pay special attention to this age group. To really empower them to go ahead. So we started some work. Our first study was in 2006. We recruited 122 sickle cell patients between these ages, 15 to 19-year-olds, just in particular that 5-year period. And we did a questionnaire-based study on them. The questionnaire was based on this Jamaica Youth Risk Survey that occurred in 2003-2004. We used similar questionnaire to that so that we could make comparisons with the national sample of youth. We also, in addition, assessed sickle cell knowledge, their disease severity and health beliefs, and we studied many modules looking at risky behaviors such as sexual health, alcohol, smoking, and so on, mental health, body image and weight perceptions, physical activity. I'll show you some of the results. So looking at knowledge, again, to all of you social scientists, these kind of numbers are probably not very different. Females had better knowledge. These are some regression models I'm showing you. Females had better knowledge. So the female sex was the one significant predictor on knowledge scores. And those who had better knowledge, look at these two, those who had better knowledge they perceived going to the doctor, attending care, paying attention to their health to be beneficial. These are what we call health belief. This is coming from the health belief model, which is important to understand in a person, especially with chronic disease, to improve their outcomes. So those with better knowledge perceived benefits to attending for care, and they perceived less benefits, this is a negative coefficient, to attending for care. So they perceived benefits and they perceived less barriers. They were more able, they thought it was easy enough for them to look after themselves and so on. So knowledge, better knowledge about their disease can impact a lot of good things that we want. Look at this slide, this is looking at risky behaviors. And a lot of times we doctors and nurses, healthcare professionals, we are so, we don't think, when I see a teenager with sickle cell, I'm just so worried about their health and making sure they stay alive. I'm not even thinking that they're having sex. Okay? But look at this, almost same number to the national sample. In our 15 to 19-year-olds, compared to the national sample of the JYRRS, the Jamaica Youth Risk and Resilience Survey, 58% of them were having sex, 50% of SCD teens were having sex. Realize that risky behaviors are a huge risk for physical health in patients with sickle cell disease. For a girl with sickle cell disease to get pregnant is a very high risk event. All right. So the risks when you have chronic disease present, the risks multiply. Right. So we really need to be thinking, and this study really puts us in that mode of thinking. More sickle cell teens were using alcohol. This is a persistent result, right? Than even the national sample of teens. Almost 3/4 were using alcohol. Risky behaviors were coexisting, meaning those who were having sex were also drinking alcohol, and those who were drinking alcohol were also smoking the weed and smoking cigarettes and so on. All right, so risky behaviors coexisted. I'm sure Mrs. Barrett knows these numbers better. And these were, this was quite exciting for us. Social factors were the factors that seemed to improve or decrease these episodes of risky behaviors. Living with a parent versus living with a non-parent. And currently being in school versus being out of school for whatever reason. These were protective factors, okay? At least what came out significant was in those who were having sex. So once you were living with a parent, although if you were currently attending school, you were less likely to be having sex. This was scary. We know chronic disease is associated with depression. A lot of work happens in young adults and adults. But look at our teenagers' results. Depression in almost a third of the sample are high risk for depression versus even this, this is significant for all of us. 20% of our teenagers, this is a national survey of Jamaica, at high risk for depression. Attempted suicide, this was even more scary. We never asked this question. I'm a doctor for the last 25 years. I don't think more than once or twice I've ever asked any teenager if they've ever attempted suicide. And look at this, 12%, 20% of our girls reported having attempted suicide, not thinking of suicide, versus 10% in our country. 15 to 19-year-old girls, 10% of 15 to 19-year-old girls made an attempt of suicide. I'm going to leave out a couple of slides. Those at higher risk for depression, presence of sickle cell disease, sickle cell teens were at a higher risk for depression. Girls were for a higher risk for depression. Those who thought themselves to be overweight or underweight, this issue of weight perception, were more likely to be depressed. And again, some protective factors, and they're all social factors, not how severe their disease was or how badly they're doing in school or anything. But those who had higher number of friends, more than 3 friends compared to no friends, had a lower odds of being at risk for depression. Those who were currently in school, once again, had a lower odds of being depressed. Those living with parents, not quite significant, but almost lower odds, okay? Attempted suicide, again, sickle cell teens were much more likely to have attempted suicide, almost 2 times as likely. Girls, again, 4 times as likely to be attempting suicide versus boys. We saw that in the earlier. And those who weren't satisfied with the way their bodies looked, right? So, these are very recent results for us. We just were analyzing this a couple of weeks ago and quite scary. So I'm going to leave the recommendations to the end. We went on and we thought it was important to do something for these teens. We are hoping that we get enough backup resources to be able to do formal counseling for when our children are becoming teenagers. And we developed this guide, this booklet that we can hand out to our teenagers. And we decided in our next study to study whether this booklet may have some impact. We started our study called the Know It study, and this was to determine the effect of an educational intervention on knowledge, perceptions, how they perceive their illness and the quality of life in sickle cell teens. And this time we were studying 13 to 19-year-olds. We also used formal counseling as another intervention tool, and we recruited 150 teenagers and randomized them to one of 3 groups. Group 1, who got routine care with no intervention. Group 2 got the booklet given to them along with whatever routine clinical care they get. Group 3 got the booklet and they got a formal counseling session. And they were tested at time 0 when they were recruited to the study, and once again at 3 months, 6 months, and a year post-intervention. Don't have all the results. I have all the results, not been analyzed yet, but I'll present you some early results. At baseline, girls were a little bit older, so we'll keep that in mind when we analyze the rest of the stuff. But look at this once again. This is a second study, but 7 years later, once again, girls had higher knowledge scores, significantly higher knowledge scores than boys, and boys perceived their quality of life to be significantly higher than girls did. This is stuff we know from the literature, but this is happening, you know, girls better knowledge, but for some reason over and over we keep seeing this. They perceive their quality of life to be lower. And when you look at regression models, and this is again baseline results, quality of life in regression models are lower in girls, lower in those with more severe disease, and greater in those with higher levels of education. Keeping them in school is what is coming out to us, because a lot of our sickle cell teenagers tend to miss a lot of school. We've been working over the last 10, 20 years to ensure that they stay in school. Knowledge though, higher in older teens may be expected, higher in girls, higher in those with internet access, higher in those with higher level of education. Not many other social factors were coming out. At 3 months of post-intervention, everybody's knowledge went up significantly. There were significant changes in all three groups. Everybody's knowledge increased by this number of points. However, there was no effect of intervention at time 3 months yet. We wait to analyze 6 months and 1 year's data. We noted no change in quality of life at 3 months from baseline or by whichever group they were in. But we did find that adolescents who had higher knowledge scores had better understanding about the disease on a whole. They thought they perceived that they were more in control of their illness, which is what you want, self-efficacy, right? For a chronic disease, it's extremely important for your patient to feel that they can manage. It's one of the basic things. You don't want them just depending on the healthcare professionals. You want them to perceive that they have some amount of control, and they also perceive a better effect of treatment. They thought, yes, my treatment can help me. Those are positive factors that we want to see. Quality of life, lower in patients who had more severe disease, and also they perceive themselves to have bad consequences. Their disease is going to have bad consequences, and the disease, they just had very many negative beliefs about the illness. So once again, boys have lower overall knowledge than girls. Girls have poorer quality of life. And we really need to understand these differences. And then maybe you guys from the social sciences need to help us in designing interventions that are going to be these gender specific. Because trust me, I'm a GP, I don't necessarily understand all the theories and all that. I'm thinking of going and talking to gender people as well. But, you know, so these are some of our recommendations that we try to implement in our own clinic. But this is my last slide, and we definitely try to work with all of these areas. We work hard to reduce school absenteeism, and we are seeing this in our data coming out as well. It's telling us keep the kids in school, improve their knowledge, improve their self-efficacy, self-esteem, etc. We communicate with school authorities, teachers, and so on to help us in helping our teenagers and so on through the school system. We provide age-appropriate counseling. It's very important for my teenagers to understand the risk of drinking alcohol is bad enough in any of us, adult, teenager, child, anybody, but worse when you have a chronic disease on board. A lot of poor outcomes can result, and I'm sure Dr. Toppin is going to speak to some of that as well. Career counseling is very important for teenagers with a chronic disease. Some things you might work with, and some things they might not be able to work with. Reproductive and genetic counseling, don't have time to go into that, but it's a genetic disorder. The prevalence of sickle cell disease can go to 0 if everybody understands how your baby is going to be born with sickle cell disease and take steps to prevent that. I'll leave it at that. And the family planning options that exist, because we see that they're having sex. The risk of pregnancy is extremely high. Risk of unplanned pregnancy is high for any teenager. Worse in somebody with sickle cell because they can die as a result. And very important to provide psychological and social support. There's a lot of stigma that may be attached to the disease. Very important for them to be empowered to negotiate the healthcare system, to negotiate their social environments and their communities, negotiate their lives, and So we work on all of those aspects to help them have better outcomes. Thanks to all the participants. We have a big plus at the Sickle Cell Unit in Jamaica. In fact, all studies that are conducted in Jamaica, Jamaicans are very, very willing to take part in research studies, and help out. We got the UE Principals New Initiative grant for the Know It study as well, and these are co-authors on different parts of the study, Professor Marlyn B, Dr. Komal Bhatt on the 2006 study, Professor Knight-Madden, our director, Nurse Grindley, and Mrs. Barton-Gooden on the Know It study. So thanks to all my colleagues. I'm just the speaker here this morning, and thanks to all of you for listening.
Thank you, Dr. Asnani, for a very interesting presentation, and we heard her speak about the chronic diseases, but not only that, the impact and the interrelation of all these other factors, the psychological, the social, and the various elements that are at play in young people with chronic diseases. So we're going to have a very interesting discussion session, but note your questions, the questions that you have for Dr. Asnani, and when we get into our discussion, then we will be able to engage with her. So we're going to move into our next presentation. So thank you for that, and I understand that you did very well with time because I didn't see any flags from our timekeeper. So excellent. So with that means more.
I kept her engaged.
But thanks again for that presentation. We're going to move now to Norwell Hinds, who is online.
Yes.
Who is online? Do we have him?
Yes.
Yeah? Okay, so
Next.
Norwell is going to present on youth accessing sexual and reproductive health services from 2009 to 2014, a case study of the GRPA. Norwell?
Yes, we're going to share your PowerPoint so we can see.
Okay, no problem. And I got all dressed up today, so you guys can see me, but with the PowerPoint up, you won't see much of me. I want to say, you first of all, to the coordinators, particularly Dr. Terry Ann Gilbert Roberts, who has been, I think, tremendous in the region in the work that she's been doing. I regret that I couldn't be there myself. I think it was an opportunity to meet a set of young people that are really going to be the movers and shakers in the Caribbean region, and particularly towards the achievement of the Sustainable Development Goals. I also am happy that a friend and former colleague as well, when I worked at UNFPA, these are women who were my mentors and guided me. Melissa McNeil Barrett is chairing this session, so I know that there's a lot of UNFPA involvement and participation, and I feel that I'm therefore part of the family. I'm going to bring up in my presentation, as you know, I'll be talking about GRPA's work in this area. Our abstract is called Youth Accessing Sexual and Reproductive Health Services, the case of GRPA 2009-2014. So I'm going to bring that up now. So you won't see any more of my wonderful face.
Okay. Alright. Put it in the PowerPoint board now.
Sorry?
Put it in the PowerPoint, the slideshow mode.
Slideshow.
Yes.
Okay.
Alright. Alright, I seen it. Take one.
Technology is working for us. All right. So the presentation, access. Access is one of the 5 areas of the IPPF mandate. Sexual and reproductive health services, and the case of GRPA, take 1, youth. So let's briefly say where we are in relation to the SDG, since the particular focus is on the Sustainable Development Goals. I'm going to talk about young people, who they are in the context of this presentation, understanding the condition, the conceptual framework, youth risk and vulnerability in Guyana, protective factors, where are they, and partnering with you, the GRPA case, is finally what I'm going to share about. Now, as you know, the work but signed off on the Sustainable Development Goals, 17 of those goals, just a few days ago, really, in the United States, in New York, at the UN General Assembly, and the Special Summit on the Sustainable Development Goals. So we're just at that point, following the Addis Ababa agenda, where they discussed the financing for development model and all those different things. So now we are in full stream to go ahead with the implementation of the sustainable development, equity being major themes within the sustainable development goals themselves. Now, first, ages 10 to 24 and adolescents ages 15 to 24. So, when we talk about young people in the context of the presentation, we're talking about young people as the cohort, the age cohort, 10 to 24. We're also talking about the stage in life. Development is the physical, social, emotional process that occurs during this time. In Guyana, these ages 15 to 24 represent 17.48%, and adolescents ages 10 to 24 represent 29%. 2002 census, there's a 2012 census, but the data is not fully.
Click on the PowerPoint.
In terms of the graphic, we're looking at young population. The image at the top shows you the Guyana's pyramid for in 2000, the year 2000, and the one at the bottom is in 2010. As you can see, there has been growth in the age group between 25 to 29 and 20 to 24 between 2000 and 2010. So in terms of understanding the youth condition, it's important to recognize that there are the underlying risk or protective factors which influence adolescent behavior, lead to adolescent outcomes, and those become adult outcomes. So that's the framework generally when we approach the situation of youth and reproductive health and adolescent health services. All of the issues surrounding youth access to sexual and reproductive health services operate in a broader context, which is the societal context, the policy and legal environment, specific programs that are by agencies such as the United Nations Population Fund, in this particular case, the Guyana Responsible Family Association, and then the individual risk factors, the protective factors, which relate to media, peers, the community, family, and so on. And applying to the Caribbean in general, sexual abuse was unacceptably high in the Caribbean and socially accepted in many countries, which is an issue. Sexual debut was the earliest compared to any other region in the world. The high incidence of rage among youth, 40% in school youth, linked to sexual and physical abuse, poor school performance, and violence. High unemployment rates, high levels of youth violence. Young people, some carry firearms and use those things, particularly in gang-related violence. And social acceptance of marijuana and alcohol in schools. In terms of Guyana context, young people take higher risks in general, including in protected sex. Young women are less able to negotiate out of sexual pressure and coercion. Young people in disadvantaged circumstances are vulnerable to sexual exploitation for favors and financial support. Young women, for biological and cultural reasons, are more susceptible to child. Within the context, therefore, considering the environment that you just described and those conditions of youth, Some of the reasons why young people may not access such reproductive health services include the national laws and policies which restrict access to care based on age and or marital status, inconvenient hours of operation, and this particularly for government-run clinics. Lack of convenient transportation. Young people are usually unemployed or in school, and therefore often don't have the means to move about on the vehicle as they are trying to practice. High cost of services, for the two reasons connected. Poor understanding of the changing bodies and needs. Insufficient awareness of the risks associated with early pregnancy and STIs and HIV. Lack of knowledge of the available services. Lack of awareness regarding the location of reproductive health services. Belief that the services are not intended for them. Concern that staff at the outset are mental. Concern over privacy and confidentiality. Fear of medical procedures and contraceptive methods, including their side effects. Embarrassment of needing or wanting reproductive health services. Fear that parents might learn of their visit. Shame, especially if the visit follows sexual coercion or abuse. This is from Senderovitz, Hansworth, and Soto Pathfinder International. That's their list of reasons. So what do we know in the Guyana case? In Guyana, HIV incidence is 1.2% in 2009. There are approximately 4,000 persons living with HIV. HIV prevalence in youth is estimated to be 1%. Studies have revealed that greater HIV prevalence among subpopulations of men, for example, men who have sex with men, 19.4% in 2009, personals at 5.24% in 2008, and minors 3.9% in 2003. When we look at the center of HIV cases by age group for the period 2006 to 2011, we see that the age group 30 to 34 consistently have been the highest, have come to the highest number of HIV cases between 2006 and 2004. Our thinking is that people who exhibit HIV in their, or who test positive for HIV in their 30s probably contracted HIV in their 20s. And this speaks to the earlier point we made about the factors which influence the model, conceptual model, where health outcomes in adolescents and youth also feed into those outcomes in adulthood. The BBS data from 2009, which we established for the purpose of this ABAC presentation as our baseline year. This is the biological behavioral surveillance survey in 2009 indicated that in and out of school youth, male and female, report acceptably high rate of STIs in the last year prior, 8% and 3% respectively, and high rates of transactional sex and sex with non-reproductive partners. Reported life number of sexual partners for men aged 15 to 49 is 4 times that reported by women of the same age group. So this is just some charts. 2009 being our baseline year, we looked at out of school youth and school youth. And you see in school youth, very significant. These are some symptoms. 50 minutes to 5 minutes. Anyway, 5 minutes to go. So these are all slides related to the conditions of the young people. After sexual debut, 16 years of the school youth, and 14 years in school based on the same treatments. So what have we done in this period? GRPA recognizing this and looking at its own data, which I'm going to show you a snapshot of for the period from 2009 to 2014. We look at our total services in terms of using 2009 as a baseline year. And if we look here, we have a list of all the services which are provided to young people. They range from broad categories: abortion services, counseling, STI management, HIV, and general counseling and non-SRH services. Between the period of 2009 to 2014, in general, there was an increase in the number of young people accessing services at GRPA, and this was largely due to specific youth programs geared towards youth. The youth advocacy movement of GRPA implemented the Healthy Lifestyles Project in the period, and other programs funded by the UNFPA in particular targeted family planning specifically, and later programs that targeted specifically teenage pregnancy and support teenage girls. In 2014, last year, we began to negotiate, recognizing these issues, began to negotiate the Choices Project. And the Choices Project has three objectives based on what we call the package of essential services. This is the IPPF package of essential services in order to boost youth access to these services, these essential services. GRPA began implementation in the private period of 2015 to focus on, in the first case, increasing the reproductive services, specifically counseling, services, safe abortion care, STI treatment, HIV, gynecological management, prenatal and postnatal care, and gender-based violence. For the period, we looked specifically at some of the challenges which had emerged in looking at adolescent access to sexual reproductive health services prior to 2015. And using 2014 as our baseline year, we constructed distribution for the project based on the sub-cohort that's within the age group 10 to 24. So if we're looking here on the table, there we've got the target this year. The first target, the number of young clients who came to the GRPA for the first time and received clinic services. We're looking on average to increase those services by 100% in 2015. And if you look at that, this relates to the targets that have been developed in response to our findings of I'm using 2014 as a new baseline year after analysis of what happened in 2009 and 2014.
You have 1 minute. 1 minute to go.
Okay, thank you. I'm happy now. So, GRPA, a Choices Project, also focused on the second objective, which is access to comprehensive sex education, and the third having to do with advocacy to improve that framework, the environmental framework for people's access to reproductive health services. One of the campaigns that we have launched recently, because what we have done to focus on is improving young people's autonomy over their sexual behavior, and we've launched a campaign called Body Boss, and that is talking about how it is very recognized is that there are certain approaches and strategies which have worked traditionally with young people in terms of increasing the access to sexual reproductive health services. One is to see young people themselves as partners and leaders in their own sexual reproductive lives. And the Body Boss campaign emphasizes that. We strive also gender transformative programming, looking at the broader spectrum of gender, age-appropriate programming, youth-friendly services within the clinic, and youth participation for all levels of programming, which we feel is good for success. I want to thank you for the opportunity to speak here and for facilitating me in this way electronically. Thank you.
Can I ask you to come up because he can't hear? He stand far away. Good day, Norwell. My name is Monika Asnani and I'm from St. Lucia, and I am very much interested in promoting sexual practices and social media sexual, I shouldn't say practices again, but the habits that young people have. Because right now we're looking at a lot of pornography with young people, and it's linked to high rates of teenage pregnancy and high rates or increased rates of HIV also. So what would you recommend for a young person trying to enter that field to make an impact to help deter other young people from engaging in such practices? Because I'm young, however, I did benefit from projects of funding from the UN and these big organizations back in the earlier 2000s when all the hype was HIV. But I realized that all that money stopped coming in and the projects have stopped. So what do you recommend?
Okay.
Thank you very much for that question. Norwell, just a minute before you respond. Let me see if there are any more so that we can take. No, hold on just a minute, Norwell. Before you respond, we're just going to see if there are other questions that we'll take. If there are 3 questions, we take the 3 at once and then you respond. Please, is there another? So just note the questions, Norwell, and then we ask you to just respond to all of them at the end. Okay? Derek?
No problem.
All right, thank you. Oh, I'm sorry. Please, you didn't tell us your name. Oh, you did. I heard it. Okay. Okay, good. Thanks. And introduce yourself.
So you should repeat your name, please, and then we get it properly.
Repeat your name.
Shout again. Tell us your name again.
My name is Zanda Daisy.
Xander Daisy.
Xander Daisy.
Xander Daisy.
Okay.
Thanks.
Okay, good day. I am Natalie James from the Jamaica Civil Service Association. My question is regarding discrimination. I'm aware that in Jamaica we have policies so that organizations don't discriminate against persons with HIV. But what I want to know is what can we do to increase the awareness for the employees who are discriminating against persons with HIV?
Thank you. It was Natalie?
James.
Jane. Thank you, Natalie. And we have one final question.
This is Antoinette. I would like to find out more about your gender-based services, because we tend to look at reproductive health as being only a woman issue. So I'd like you to tell us a little more what services are offered.
Thank you so much. Any more? Those are the 3. No burning questions? Good, thanks. Norwell, you got all 3?
Can I get the name of the last speaker? The last question?
It was Antoinette. And you got the question?
Yes, I got the question.
Okay, good. So we're going to ask you to respond to those 3 questions, please.
Okay. Well, thanks very much. Indeed, these are excellent questions. Somehow I feel like an expert here. I feel fancy. Feel nice with my suit and stuff. I'm just joking. So, Xander, your question concerning reaching young people where they are with positive behavior and or communication towards behavior change. Now, first, I don't know necessarily that there's a correlation between sexual expression in the form of looking at pornography or even masturbation, those things, and other sexual health outcomes such as HIV, transmission, or the contraction of HIV, or teenage pregnancy. So I would say that that's not always necessarily the case. What is important and what we have found in our work at GRPA, certainly in the work with young people, is to emphasize autonomy. And this is why this social media campaign, if you look on Facebook, hashtag BodyBoss, hashtag BODYBOSS, this is a campaign that was launched just a few months ago as part of our Choices project, because what we're looking to do is to encourage young people to see themselves as sexual beings and to be responsible for their sexual health. And I think that approach usually works. Emphasizing autonomy over sexual expression and emphasizing positive and responsible sexual behavior. So I would encourage you to do that, and you can always check out the social media campaign, because we do a lot of education through social media. Ms. James, my friend talked about discrimination. Yes, it's a significant issue, particularly in the Caribbean and in Guyana as well. In the Europe of HIV work, it's indeed a lot of the funding is shifting to other priorities now. But what we learned a lot from HIV work is the need to engage workplaces. And here in Guyana, we do have an HIV workplace policy. I'm not sure if there's an HIV workplace policy in Jamaica, but I suspect there is, because a lot of the programming for HIV throughout the Caribbean was facilitated by Contact, and more or less they apply the same approaches and principles. So I suspect very much that what is available here is also very likely available also here. So I think it's important to deal with that. And the final question, having to do with gender-based programming and the full spectrum of gender programming. Definitely we recognize that programming for boys has been a challenge. Traditionally and structurally, health services have been geared towards women and soon-to-be mothers, so pregnant women and children. So there have been structural issues, and there's Professor Barry Chavans, right out of UE here and in Jamaica, has written significantly about that. Professor David Plummer out of Trinidad and Tobago UE, he has also done a lot of work in relation to masculinity and machismo. And here in Guyana, Patrice Lafleur, who is the UNFPA assistant representative, she years ago prepared a paper, a study, What Make Man Stay So. So they recognize that there are a lot of structural issues and social issues affecting male access. So what we have found is that it is useful to engage young men and boys specifically, to have very specific programs for young men and boys, and usually to have those facilitated by a trusted and modeled young man who they look up to. So that has been our approach. In fact, as youth coordinator at GRPA, I attempted myself to model some good behavior, good sexual behavior, and good presentation for the young people there. We've also recognized that it's important to focus on key populations of youth and to facilitate the access at the clinic. So Body Boss, even though it speaks to autonomy, in fact, because it speaks to autonomy over one's sexual expression and sexual rights and so on, we have been able to bring into the discussion through the Choices Project the services for transgender persons, for LGBTI community, and what are some of the specific needs there. For example, the conversations we've started about particular education around hygiene for the young men, need for lubricants, which has not been easily accessible for the sexual practice of gay men.
Okay, Norwell?
And attitudinal change.
Norwell, can you hear me?
In the country.
Hear me? Okay.
Yes, sir.
Thank you so much, and I'm sorry to cut you because this is always such an exciting issue, and you know I have my own bias when it comes to sexual and reproductive health discussions, but because of the time factor, I'm gonna thank you for those responses. I do hope that you can stay with us a little longer, but you know, to see if you can join us later for the discussions. But if not, then certainly I'm sure that some of the points you raised will come up again in the discussions. So we want to thank you very much for those responses. Thank you so much for that presentation, which I'm sure will be shared as a part of the outcome of the workshop, or certainly the points that you have raised. So we thanks for your input. The presentation was a little fuzzy at times. We couldn't hear you very clearly, but we were happy to see the presentation and to hear the points that you have made. So thanks very much. We hope you can stay or join us for the discussion. But certainly, I know that those issues will re-emerge, and the points that you made have been very useful. So thanks, Norwell, and thanks, colleagues, for the We're going to move right into our third presentation, and that's Dr. Toppin is going to talk about patterns of violence-related injuries in 15 to 29-year-olds presenting to the Cornwall Regional Hospital.
Good morning, everyone.
The code.
Morning. I'd just like to say thanks for the opportunity to present. This is actually part of a bigger, larger project. Pulled up some of the data and decided to look at for this conference. Just in terms of background, injuries of all kinds represent a significant burden to health and social systems throughout the world. And as is often the case, this burden is borne disproportionately by the developing world. It's a pretty telling statistic. Deaths from injuries exceed those from HIV, malaria, and tuberculosis combined. It also affects young people predominantly. It is largely a disease of younger people. Yes, I think we can refer to it as a disease. And these are people who are entering what should be their most productive years, who may die or have significant injury and disability. And WHO has a number of times highlighted the urgent need for interventions. The impact on Jamaica as a whole is pretty obvious, and frequently in the media we have a very high rate of murder and violence-related injuries, one of the higher in the world. Estimates of the direct cost of these violence-related injuries is that this is a study, so this is data from 2008, published in 2009, about 2.1 billion Jamaican dollars for that year. And these are just the direct costs. In terms of our health system, it impairs our ability to deliver care to other non-trauma patients. If you ever had a relative who's been waiting for a surgery that's been cancelled a couple times, because when they arrive there's some trauma going on and emergency surgery has to be done. I alluded to the direct cost, which is the cost of providing medication, fluids, taking care, x-rays, blood tests. But less obvious, but often much more significant, are the indirect costs. A number of people may have left with long-term disability. These costs, the cost of taking care of someone who is now paralyzed or has lost a limb, often will fall on the family. There's a loss of income, so if these people are gainfully employed, that income is no longer available to their family. Maybe even a little less obvious, but obviously real, is loss of investment in terms of Jamaica as a whole and communities as a whole, as people divert their funds away for fear or concern of violence. And this is a study done, published by Dr. Ward, 2009. It is estimated to exceed about 26 billion Jamaican dollars per year. Solutions in terms of violence-related injuries, I'm willing to bet, definitely this media, that absolutely we should build another prison. That's perfect, that's great, and we need more police. As a physician, that would be akin to saying, let's just take care of people after they have a heart attack. Absolutely ridiculous. how about we stop people having a heart attack in the first place? So bring this to what I call a public health approach to violence prevention. And public health as a whole, this is how we start. We get some risk factors, what makes people at risk, what protects them. I develop some strategies to intervene early in the process, and then I put them in place and I monitor them. Are they working? Are there new factors that develop as we go? Who is at risk for being a victim or committing a violence-related injury? What do they use? Where? What are the circumstances involved? And I want to find factors that not just increase risk of being involved, but what are the protective factors? What are the things that make someone in the same community, the same surroundings, succeed, as opposed to the neighbor next door who may not? So to plan an intervention, we need good data. What are the demographics of people who are victims or perpetrators? Where do they live? How old are they? Within communities, where do these things occur? What are the circumstances around these conditions? Which brings us to the study that I've taken some of the data for. It's big long name, analysis of the epidemiology and cost of violence-related injuries and motor vehicle accidents to the healthcare system of Jamaica. So the aims are just epidemiology. What are these risk factors? This is us trying to find the risk factors. We want to find the costs associated with them, and I'll just briefly go through with the example of 15 to 29-year-olds presenting to the Cornwall Regional Hospital. Although I'm focusing on Cornwall, but this is actually a number of major hospitals: Kingston Public Hospital, Victoria Jubilee, University Hospital, Mandeville, Maypen, St. Anne's Bay. So it's not quite comprehensive, but almost. What happens when patients arrive in the accident and emergency room? They're flagged. Road traffic crash, violence-related injury. During registration, we collect some basic demographics and we flag to follow up some specific information looking at costing related to that patient later on. So looking specifically at this data, this is a Cornwall Regional Hospital, the major hospital in the west of Jamaica. It's a 400-bed hospital. And the data is from April, May, June last year, 2014. We found 217 patients, which 116 were male, 53%, and 101 were female. So a quick peek at what some of the things we found. The most common person who inflicted this injury was an acquaintance or a friend. Stranger pictured more prominently for males, not so for females. And I also highlight for female, very significant was boyfriend. Where did it occur? The most common place was public or street. Second was at home, where you might suspect might be a place of safety. For a female, the most common place was at home. This is looking at mechanism of injury. I didn't really find anything too exciting there. Circumstances: fight, robbery, gang and drug related, not so big. Sexual assault, obviously a big difference. Features more prominently in females. Just a little summary of what we found so far. Similar numbers of males and females, which all the data is a little different. It actually suggests there's more females who are presenting, who are being victims of violence-related injuries. You do not need to fear strangers. It's people you know that are more likely to commit this injury. Females are more likely to be injured by an intimate partner. Public place is the most common place of injury, but home is not that far behind, and for females, home is the place where these injuries are most likely to occur. Second part of what we're doing with the data, we're mapping it. We're putting it on where does it occur, and we're mapping it with community assets, businesses, churches, open lots. What are places, what are factors associated with these injuries, where they occur. We can then use that to target where should we start investigation, where should we start community intervention, where should the police maybe get involved. what are the factors, geographical, that increase and decrease the risk of these events occurring. We're also estimating the costs associated, both the direct and indirect costs. That's ongoing currently. It needs to guide, it guides our potential savings. If you're going to spend $10 million and I'm going to estimate 10% decrease, that's $1 million that we could save. And that needs to guide the resources that we allocate to to preventing these injuries. You have to link this to intervention. This is just a quick slide just to show you what we're thinking. A couple of different articles. This is one that was in the New York Times, which highlights the case of Mountain View and a number of the community view interventions that have dramatically changed the amount of violence and the murder rate in Mountain View. These are some UK and US based. This UK based looking at sports related interventions, guided, targeted, proven to decrease the risk of violence and violence related injuries. And this is a community policing model in Auckland, which has also been proven to decrease the risk of injuries. Brings us back to here. So it's not enough, it's not data for the sake of collecting data. Data has to be linked to an intervention. And then we need to check. We need to follow up. Are there things that change over time? We've seen shifting in crime and violence rates in Jamaica, shifting from maybe not so much urban, shifting out to more rural areas. So we need to be able to respond. Just trying to put this all together. Some thoughts on this. This cohort, males and females, are pretty much equally represented. Majority of these incidents are occurring at home. Major perpetrator is someone known to the victims. Actually, VRIs are not so often a part of other criminal activity, gang-related, drug-related. And this is overall, not necessarily those that result in death. And the question I came up with, I'd ask, has violence become more and more a normal part of home and day-to-day activity? I'm kind of putting it off, which is commenting on the system that we hope to have in place. That the system we've set up, which we'd like to hope to remain in place, is a system that we could guide interventions. And then that same system would allow us to monitor and see what's working and see what has the pattern changed, allow us to pick up changes and respond. Thank you.
Thank you so much, Dr. Toppin, for that very interesting presentation. I'm sure that we're going to have some excellent questions when we get to the question and answer section, because that was so interesting and very telling some of what is happening with our young people. And we're going to move straight into our final presentation from Ms. Title Heron, Make Them Stay With Them Law, Unsafe Abortion and the Agency of Women and Girls in Jamaica.
Thank you. The title of the paper actually changed a bit after I submitted the abstract. First part is the same, Make Them Stay With Them Law. But the second part reads Unsafe Abortion and the Agency and Voices of Women and Girls in Jamaica. I won't be able to present everything, so I'm just going to try and condense everything. The voices and the agency that I'm going to speak of this morning basically comes from about two different focus groups that I had with two groups of women, 15 to 43, and then about 4 different elite interviews roughly 2 years ago. Essentially what I aim to do is to look at what the women who have had unsafe abortions say about the experience, and what do they say